Thank you for the invitation to talk to you about the really fundamental issue of why nations need deceased organ donation. The bottom line is that end-stage kidney failure treatment is very expensive and non-treatment is very destructive. The catch is that kidney failure treatment is both expensive and destructive of communities if it's not well managed. And this is especially true in lower and middle income countries, and especially true when healthcare financing for tertiary healthcare is predominantly private funding. I'd like to take you through the average patient's journey, and in doing so, provide a number of options for the intervention, which need to be considered before you get to the expensive bit at the bottom. CKD, chronic kidney disease, has a series of classified steps. And on the right-hand side of the screen, you will see the development of interventions which can make a difference. They retard or prevent the development of end-stage kidney disease. And people say, well, you know, you're only slowing it down by a little bit. But if you slow the progression of chronic kidney disease down by 5 years or 10 years, you make an immense difference to the number of people that you treat with end-stage kidney disease. And so programs of screening, difficult to implement, but through primary practice, weight control, exercise, blood pressure, cholesterol, glucose management, all the simple things that improve healthcare dramatically alter the outcome for chronic kidney disease. It's when you get to stages CKD 4 and then to 5, end-stage kidney disease, that you really need to start intervening with expert interventions, particularly hypertension control throughout this process is an important feature for LIMC countries. So what we have is shown here. And, you know, we don't really have a screening program. We do screen in diabetes clinics, in cardiothoracic clinics, in cardiology clinics, but we don't screen generally. General practice and education programs throughout the Australian community are essential for managing early chronic kidney disease, and we reckon that we could have about 8% of the Australian population needing these interventions at an early stage. Hypertension management, diabetes management, weight management, exercise. It's only when you get to CKD3 that we advise renal specialist services. And then as we get to CKD4, as the kidney function declines, we then have specialist education programs for patients so that they're better able to select their route forward and understand their process. It is far better to intervene at an early stage and plan than it is to wait and let the outcome appear in an emergency department with a serum potassium of 8.5 and a creatinine in the sky, as with end-stage renal failure. So an education program. And then when you get to chronic kidney disease treatment, you do need multiple expensive interventions, and that is why it's such a problem within the healthcare environment of LIMC to provide all of these things: surgical dialysis access, home hemodialysis education and support. It's cheaper and better. home peritoneal dialysis education and support. It's a big problem in environments with low levels of sanitary arrangements. And then transplant education, assessment and waitlisting, and satellite in-center dialysis support. All these things cost a lot of money, and it's not easy to implement for a population. So if we look at what happens with the development of end-stage kidney disease, patients arrive, they go to the emergency department. They either die or you start dialysis. And if you start dialysis, you start as an emergency, and then you place people on chronic dialysis. An alternative is if you've got it diagnosed before the critical point, before crisis, is you can transplant patients. And that, of course, is the most logical and appropriate way to do it for quality of life, and also for reducing costs. There is no point having the expensive cost of starting dialysis if you're going on to transplant, if you can organize for the transplant to happen first. Problem. If you look at this in numerical terms, you might have 100 per million or 200 per million patients commencing end-stage kidney disease, and it varies around the world. Asia has some quite high rates. Let's say 200 people per million population are eligible to start dialysis and start on the dialysis program. Between 10 and 20% of people on dialysis will die every year. So of your 200 that have gone on, let's say that 40 patients on dialysis have died. So at the end of the year, you've got 160 patients more than you started per million population. And the next year, you get another 200 per million starting dialysis, and another 40 dying, and you add another 160. So you've got to double your dialysis program in that second year. And you have to keep increasing that. And so the only way to put a control on this number is either to simply not dialyze patients, in which case they die, or to transplant them. And it's better to transplant them ahead of time, if you can. But if you can't, transplant them off the dialysis program. Transplant is superior, it's cheaper, and it's better, and patients live longer. If we look at the United States, this is old now, it's about 20 years old, but the slide is the same now. I could just change the numbers. I think they're spending $60 billion a year on dialysis in the US currently. It's 6 to 7% of the entire US health budget and 1% of the entire federal budget on dialysis only. About 600,000 people benefit. It's a massive expense, completely disproportionate. You have to transplant. And that is the pressure to transplant. This slide comes from the Global Observatory on Dialysis and Transplant, the WHO database, which comes from national figures. And it shows the number of patients transplanted. In blue is the number from deceased donors, and in yellow is the number from living donors. It includes kidney and liver and other forms of transplant. About 140,000 patients transplanted. It's still a fragment of the total numbers, but you see the massive differences per million population. Maximum number, about 100 per million population. They can, at that rate, intervene usefully in the volume of dialysis activity. If we look around the world, we see the numbers of patients transplanted per million population from living donors. You see a couple of countries with massive numbers. Korea is one, Turkey is another. You see numbers that are in the 20s per million population, Saudi Arabia, for example. And then you see numbers around the 10 to 20 per million population across much of the world. And so living donors at a rate of perhaps 10 to 20 per million population is achievable in many countries around the world. But there is a problem. And the problem is this: when healthcare funding is at this tertiary level provided by the private pocket, it's provided for wealthy people. And mechanisms of greed and survival come into play. A wealthy person will do what they can with their money to survive. Simple. And so there's money flying around. And with a lot of money flying around, there are many brokers and, unfortunately, many unscrupulous surgeons and physicians who wish to take advantage of that urge to survive by the wealthy. They can afford transplantation. And what happens is women and the poor are placed at risk. Wealthy people won't put their own families at risk if they can avoid it. Moderately wealthy people will put the women in their family at risk rather than the men. And there are all sorts of reasons for that. Many of them economic, of course. But we then get these lineups of predominantly male donors, living donors, who are encouraged to receive money for their organs, their kidneys predominantly, though livers are also being purchased. The man in the middle was arrested in India for undertaking about 800 kidney transplants from living donors on a commercial basis and transplanting them for money. He's not a surgeon. He's not a physician. He's not medical. He was a hospital orderly in a theatre and decided that he could probably do that job. And so he set up a cottage. And many, many people ended up being transplanted and selling their organs. It is not clear how many of them survived. So living donation in a predominantly privately healthcare financed tertiary sector inevitably leads to unethical practice and organ brokers, unless it is heavily regulated and properly regulated. So I mentioned women. If we look at the Global Observatory for countries that record the gender of the recipients, you see here there's quite a wide range of proportions of male to female recipients. Predominantly, though, you see that recipients represent more than 50, certainly more than 60 sometimes, up to 80% of all recipients, with females underrepresented. If we look at the donation side of the equation, you see here deceased donors, more male than female. They drive bicycles worse, badly. They have more work head injuries, etc. But with living donors, you see that there are more female than male in the majority of countries. So this remains an issue to be balanced. So deceased organ donation provides the route to resolve this problem. And this is the focus for this series. Deceased donation in Asia. If we look at the stars on the left-hand side of this, you see the Asian countries reporting to the WHO Global Observatory. And you see that only the Republic of Korea reaches 10 deceased donors per million population. Many other countries are struggling to achieve that rate. Deceased donation increases the total number of transplants. It allows people without ethical living donors to be transplanted. It keeps control of the total cost of end-stage kidney disease. But it requires political decision-making, national regulation, and transparency, especially for organ allocation. And we look forward to the next few talks to help decide how to progress that. Thank you for listening and the opportunity to talk to you today. I look forward to the future of this course, and I look forward to talking with you. Thank you.